Look at large-scale dietary data, and a clear pattern emerges. People who consume high amounts of antioxidants generally have lower rates of cancer. The molecules act as a first line of defense, neutralizing free radicals and protecting healthy cells from DNA damage before disease takes root. But when oncologists try to replicate that success by giving antioxidant supplements to patients who already have cancer, the clinical results collapse. In large randomized controlled trials, these same protective molecules fail to stop tumor growth. This chart compares those two realities. On the left, epidemiological prevention data looks promising, but on the right, the clinical trial data shows a different outcome. In multiple studies, patients receiving beta-carotene or vitamin E saw a surge in lung cancer incidence and overall mortality compared to the placebo groups. These failures indicate that the medical community has mistakenly applied a prevention model to an established disease state. The biological mechanisms that successfully prevent a healthy cell from mutating are the exact same mechanisms that can accelerate and protect a tumor once the disease is established. Integrative practitioners frequently prescribe supplements like vitamin C, N-acetylcysteine, and polyphenols to cancer patients. The goal is often to reduce the cellular damage caused by chemotherapy. That approach relies on treating antioxidants as a generic wellness category, assuming these molecules act unilaterally to lower oxidative stress and heal tissue. But inside a tumor microenvironment, the rules of redox biology change. A single molecule can perform two different functions depending on its environment. At one specific dose, that molecule can shield a tumor from destruction. At another dose, it can rip the tumor apart. To achieve clinical efficacy, practitioners must stop viewing these compounds as universal cellular shields and reframe them as context-dependent, dose-sensitive redox modulators. Administering them without accounting for this inversion means the supplement may be working against the patient's primary treatment. An advanced cancer cell operates under massive self-generated oxidative stress. Its aberrant metabolism creates a highly toxic internal environment. It produces massive amounts of reactive oxygen species, or ROS. In fact, the tumor is constantly hovering right on the edge of triggering its own programmed cell death. To survive, the tumor upregulates its endogenous antioxidant systems, NRF2 and glutathione. This relief valve vents oxidative pressure, keeping ROS below the lethal threshold. But taking oral antioxidants like NAC or vitamin E drops this internal pressure. This drop in ROS rescues the cancer cell from its own metabolic toxicity. It provides a survival mechanism to a cell that was on the verge of destroying itself. Inside this stabilized, low ROS environment, the tumor safely stabilizes HIF-1 alpha proteins. That stabilization directly fuels new blood vessels and accelerates metastases. By giving standard oral antioxidants to protect healthy tissue, the practitioner is inadvertently supporting the tumor's primary survival mechanism. Managing advanced cancer requires a strategic shift. Instead of quenching oxidative stress, the objective is to push the tumor's ROS levels past their breaking point. This requires hitting what we call the pro-oxidant window, a specific massive dose where these supplements invert their behavior entirely. In the Fenton reaction, massive doses of extracellular vitamin C interact with iron to generate a huge spike in toxic hydroxyl radicals. Because tumor cells lack catalase, the enzyme needed to neutralize them, the cell buckles under the oxidative stress and undergoes apoptosis. Healthy cells possess abundant catalase. They easily process this localized burst of ROS and remain unharmed. Achieving this pro-oxidant inversion weaponizes these molecules, shifting the clinical goal away from cellular protection and toward targeted destruction. If this pro-oxidant inversion reliably kills tumors in a petri dish, we have to ask why it so rarely succeeds in human patients. The barrier is the human gut, specifically the bottlenecks of oral absorption and saturable transport mechanisms. This chart tracks 3 tiers of bioavailability against the red pro-oxidant threshold. Group 3 supplements like curcumin are destroyed by liver metabolism, flatlining near zero. Group 2, like oral vitamin C, hits a strict absorption ceiling, trapping them well below the threshold. By bypassing the gut entirely, intravenous vitamin C achieves plasma concentrations exponentially higher than oral dosing. Group 1 supplements, like alpha-lipoic acid, are the rare exceptions, possessing oral absorption rates high enough to theoretically cross the pro-oxidant threshold. Prescribing a supplement without ensuring the delivery route can achieve this pro-oxidant threshold is a pharmacokinetic failure. Even if a practitioner masters redox balance and bioavailability, they still have to confront the tumor's underlying mitochondrial engine. Cancer cells largely abandon standard ATP energy production, known as oxidative phosphorylation, in favor of alternative metabolic pathways. Tumors rely on alternative respiration-supported non-OXPHOS pathways, like glutaminolysis and DHODH, to synthesize the physical building blocks they need to proliferate. Specific supplements chemically interact with these backup pathways. Without realizing it, a clinician might prescribe an antioxidant that acts directly as fuel. Molecules like N-acetylcysteine increase metabolic flux through these backup pathways, accelerating tumor growth. Contrastingly, agents like alpha-lipoic acid actively block these pathways, starving the tumor of synthetic material. A supplement can successfully achieve pro-oxidant status, but still fail clinically if its metabolic side effects fuel the tumor's mitochondrial infrastructure. Translating this data requires 4 rules to navigate the redox paradox. Rule 1. Ensure anti-cancer pro-oxidant effects aren't overshadowed by tumor-protecting antioxidant activity. Rule 2. The delivery route must guarantee sufficient bioavailability to overcome gut absorption bottlenecks. Rule 3. Clinical monitoring must verify that achieved serum concentrations hit the pro-oxidant threshold in vivo. And Rule 4. Practitioners must prioritize agents that actively disrupt the tumor's respiration-supported non-OXPHOS pathways. Prescribing supplements without fulfilling all 4 criteria risks losing medical precision and can actively harm the patient. Oncology requires moving beyond empirical, indiscriminate antioxidant supplementation. The molecular identity of a supplement is less important than the context, dose, and route by which it is administered. Future clinical trials must stop relying on intention to treat oral doses and instead stratify data based on achieved serum concentrations. Natural supplements in oncology are not benign wellness vitamins. To defeat cancer, these molecules must be wielded with the same pharmacokinetic and metabolic rigor as targeted chemotherapies. This transition shifts these molecules from benign wellness additions to the rigorous discipline of precision redox medicine.